So I'd like to thank all of you for making the effort to get here tonight. I know it's a miserable night out there and traffic is terrible and the weather is awful, but we are absolutely delighted to have you all here. And we are really in for a tremendous treat this evening. We have two world experts in the field of mast cells and mast cell activation. And we are really going to learn a lot from these two folks tonight. Our first speaker is Dr. Mariana Castells. She's Associate Professor in Medicine and the Associate Director of the Mastocytosis Center at Harvard Medical School. And it is really just such a pleasure to welcome you. Thank you so much for being here tonight, Dr. Castells.
Thank you. Thank you very much. Thank you very much, everybody, for being here. My voice is a little bit gone because I had a big cold and still not better. You have a miserable weather, but it's the same than in Boston, so I don't mind being here at all tonight. My field of expertise is mast cell biology, so my PhD was in mast cell proteases, and I started some 20-something years ago interested in the field of mast cells. That brought me to actually derive my clinical interest in what is mast cell activation, and at the present time we have a mastocytosis center in Boston. We see patients with anaphylaxis, patients with mast cell activation syndromes, patients with systemic mastocytosis, and what we really do is we try to put a diagnosis to those patients, to actually label them whether they have one syndrome or another, and then the reason of that is then we can do targeted therapies. So depending on if the patient has idiopathic anaphylaxis, if they have mast cell activation syndromes or systemic mastocytosis, we try actually very hard to put a label to them. The reason being the following: there is great advances in the field of mast cell diseases, and Dr. Milner is one, of the forefronts of those advances, discovering genes that relate to mast cell activation. In the field of mastocytosis, we have also new medications. We have what we call tyrosine kinase inhibitors that really targeted the genes that are actually activated in patients with systemic mastocytosis. So if we have patients in which we are able to label them, we actually are much more able to put a therapy that will help them and not really do a one box fits all. So having said that, what I had, and this is my presentation just 2 weeks ago in San Diego, where we had our big mass allergy meeting. I don't know if I have something to point to you. Well, that doesn't matter. Let me just see if I can point with this. Does it? No video. Do you think that's a pointer, or it's not a pointer?
I'm gonna check. I don't know.
Yeah, try to use mouse, but it doesn't
Right,
really.
mouse doesn't work.
It doesn't work. The mouse doesn't work. Yep.
Use this mouse.
Oh, here we are. Here we are.
Does
we
it
have
disappear
a mouse.
when you're
okay,
on there?
Great. There we are. Perfect. Thank you. Thanks so much. So before we start, well, how many of you have actually heard about tryptase? Oh, quite a good. Yeah, that's good. That's right. That's right. That's my favorite word. When the fellows come and somebody has had a reaction, it's like, was that tryptase drawn? And a lot of times, even in Massachusetts, sometimes we have, they call us with somebody who has an anaphylactic reaction, drug allergy, or some other symptom, and we said, okay, draw a tryptase level, and they said, could you spell that for us? And it says tryptase, and then when we get the test back, we get trypsin level. So it's pretty daunting, the fact that in the general population, even in the doctor's population, tryptase is not a common word. So what I wanted to accomplish is to recognize the symptoms of mast cell activation with you, to understand a little bit the tools that we have for clonal and non-clonal mast cell activation syndromes, and then establish either some prognostic factors, and then most of it for you would be the management. And again, tryptase is underutilized. Every time that there is mast cell activation, we have the ability to draw tryptase levels. Tryptase levels are elevated when patients have idiopathic anaphylaxis, or when the patients have a reaction to medication, or when the patients have a reaction to a food or any other thing. It's very poorly understood because people are still looking at elevations of tryptase above 20 nanograms, which is something that we publish through the World Health Organization, but any elevation of tryptase is significant. And then there is something that we use a lot, which is the mutations on this molecule that's called c-KIT, and this is the molecule that we use for the diagnosis of systemic mastocytosis. Now, there was somebody in the audience asking me, well, if tryptase is not elevated, what do we do? So we have other mediators. We have histamines and methylhistamines, we have prostaglandins, and then in the last year, we have the ability to measure, and this is going to the FDA for approval, chymase and carboxypeptidase. So we have at least 5 mast cell mediators that we will have available for use. The classification of diseases associated with mast cell activation was done here, and we haven't revised yet. But primary mast cell diseases are mainly diseases that are associated with clonal proliferation of mast cells. And so this is mastocytosis and what we call monoclonal mast cell activation syndromes. Then there is secondary activation of mast cells, and in those we can include allergic disorders, we can include association with chronic inflammatory disease, physical urticaria, and chronic autoimmune urticaria. But here we have to say that in the last year we have seen patients with postural tachycardia, orthostatic like POD syndromes that have associated mast cell activation syndromes. We have also seen patients with Ehlers-Danlos that come to us with mast cell activation syndromes. So secondary mast cell activation can be actually more than what we listed here. Any diseases that there is some inflammation may potentially induce mast cell activation. And then we have the idiopathic mast cell activation syndromes, which are listed here, which is the mast cell activation syndrome, in which really there is no secondary disease, there is no secondary cause for this potential mast cell activation. So this is a patient. I'm going to have a few vignettes, and you can actually interrupt me at any time point if you have any questions. This is a male who's working in the yard, and then within 15 minutes of being stung by a wasp, he's dizzy, he collapses, and they call 911. They cannot find his blood pressure, and then they give epinephrine intramuscularly. There is no epinephrine subcutaneously, just so everybody's on board. Epinephrine has to be intramuscular and a big muscle here in the quadriceps while the patient is lying flat. And the tryptase is 40. So we actually say, okay, this is due to the wasp, and then we do the tryptase a month later, and the tryptase is 21. So what happens in this patient? So we do a bone marrow biopsy, and what we find is those black dots that you see here, all those aggregates of mast cells. So this patient has mast cell aggregates, which is the major criteria for mastocytosis, and then positive c-KIT. This is a new form of mastocytosis that was uncovered a few years ago by a group in Europe, Dr. Bonadonna and then Dr. Escribano. So patients with Hymenoptera anaphylaxis, 30% of them or more are going to have mastocytosis. And tryptase is going to give us the key for that. This is a patient who is a 30-year-old, and she has a near fatal event during C-section. She had an epidural anesthesia. She is giving all those medications for the anesthesia, and then she delivers a very healthy baby, and they clamp the cord, and then 2 grams of cefazolin is given, and 2 minutes later the patient has a hypotensive, severe hypotension. They can't find the blood pressure, 52/20. She's tachycardic and unresponsive. She is very flushed and red from head to toe, and her lips are very swollen. They give 3 doses of epinephrine. She recovers within 30 minutes. And when the event happens, she also has an elevated tryptase, but her baseline is about 10 nanograms, so that would be kind of the normal range for tryptase. And we did a skin test, and she has a skin test that's positive for cefazolin, which is a cephalosporin in the family of the penicillins. So what induced the event was an antibiotic. So why did we do a bone marrow biopsy in this lady? Well, the lady had a very severe, almost fatal event. That severity is something that may underlie mast cell activation and mastocytosis. So we looked for a bone marrow, and she did not have mast cell aggregates, but she did have what we call spindle-shaped mast cells. Those mast cells are here, they are spindle-shaped. They're positive for something that's called CD25, and she also had this peripheral blood mutation. So this patient actually was diagnosed of systemic mastocytosis after delivering a healthy baby and having almost a fatal event. So Dr. Aiken, when he was at the NIH and his collaborators published the demonstration of aberrant mast cells with the clonal markers in patients with idiopathic anaphylaxis. So this was patients who went to the NIH and they were saying, I was not stung by a bee, I did not eat a shrimp or a peanut or anything like that. I just had sudden flushing, and then my hands were very sweaty and itchy, had abdominal pain. I was doubled in pain. I went to the bathroom, I threw up, I had severe diarrhea, and this is happening in the last year 3 to 4 times. I have no idea why this is happening. And Dr. Aiken and his collaborators, and Dr. Aiken is now the director of our mastocytosis center in Boston, did look at those patients. Their tryptases you have here where, normal range, 7.9 is a normal range, 8.1 is a normal range. This is very slightly elevated, and few of them had elevated tryptases. In those patients, they found a cohort of those patients that had CD25 positive mast cells, and those patients, some of them have the mutation. So essentially, patients who otherwise, when I was a fellow, 20-something years ago, said we have idiopathic anaphylaxis. So that's it. You go out and you take antihistamines, and maybe you take steroids, and you try to be cautious about hitting yourself with an epinephrine when this happens. And those patients now are known to have potentially something that's called monoclonal mast cell activation syndrome. So having said that, the diseases that I showed you before are classified as clonal mast cell disorders. But then now we come with what we call non-clonal mast cell activation syndrome. So this is a typical case that we saw in Boston. This is a female with seasonal rhinitis, and she was allergic to the spring. In the spring, she had grasses, weeds. She had also some food intolerances. Doctor, I cannot have garlic. I cannot have onions. I cannot have soy. I have abdominal pain, some bloating. I don't feel well with those foods. The skin test was negative for all that. We tried to give her allergy shots. Actually, this was done before she came to my clinic, but she had burning hands and feet and chest pressure. She was lightheaded, and the immunotherapy had to be discontinued. And she started to present flushing episodes, cramping abdominal pain, some nausea, feeling dizzy, headaches, feet and hand were burning, brain fog, the big brain fog. So brain fog in our hands is what we used to call mixed organic brain syndrome, where the inability to concentrate, poor memory, and those patients feel that there is something in the brain that does not allow them to think clearly, and poor concentration also. The patient responded to antihistamines, H1 and H2, but she had very poor quality of life. So tryptase was normal. Here we are. We measured prostaglandins, which were again normal in this case, up to 1,000 picograms is normal range, and the methylhistamine was elevated in that patient. Her mutation was negative. We did not do a bone marrow biopsy, but we did some gastrointestinal biopsies because the patient had prominent gastrointestinal symptoms, and there was no increase in mast cells, no aggregates, no aberrant phenotype. So the patient did not have what I was telling you about a clonal mast cell disorder. So when we go back to this, we have here that I described to you patients who have associated with their disease clonal proliferation of mast cells. Those are the patients who have systemic mastocytosis. Those are the patients who have monoclonal mast cell activation syndromes. In those patients, the mast cells are abnormal. They aggregate, or they are spindle-shaped. They have CD25 expression, and they have what we call the c-KIT mutation. So in those patients, there are several markers that through the World Health Organization we can recognize, and we can classify those patients having a clonal mast cell expansion. Either the mastocytosis, systemic mastocytosis, or something that's called monoclonal mast cell activation syndrome. The patients with secondary, we have a patient here who has allergic disorder, and we think that that is the cause and the source of her secondary mast cell activation syndrome. And as mentioned, mast cell activation can be associated with many inflammatory diseases. Even in Crohn's disease, that they can be associated mast cell activation syndrome. In physical urticarias and patients who have hives, we consider that to be secondary mast cell activations. And finally here, what we have is patients in which, again, we don't have any good cause for which they would have this mast cell activation syndrome. So when we look at what I was saying initially, the criteria for mastocytosis is finding those mast cells in the bone marrow or in other organs. And one interesting thing that we did in the mastocytosis center is that people who have prominent gastrointestinal symptoms, we can have gastrointestinal biopsies. So somebody complains of abdominal pain, bloating, and having diarrhea, gastroesophageal reflux, nausea. Biopsies are very important because we can actually see the abnormal mast cells, we can see the number of mast cells, we can see how they look like and if they aggregate. And that was published by our group in 2013. The minor criteria for mastocytosis is what I was mentioning about the spindle sheath mast cells, the presence of that mutation, the CD25, and then tryptase. But as we have been talking about, 20% of the patients with mastocytosis will not have elevated tryptases. So again, we have to take other criteria for that. So you have here that mast cells are in the bone marrow, and they are here aggregated, and this is a patient with systemic mastocytosis. So mast cells aggregate, they have more than 15 in those aggregates. Here we have a patient with monoclonal mast cell activation disorder. The mast cells are elongated, they are not aggregated, but they have different shapes, and we stain that with CD25, then there's abnormal staining. So there are very clear criteria to define those patients. When there is less clear criteria is to define what we call now non-clonal mast cell activation syndrome, which was published earlier in 2011, and then by many other groups has been publishing. So here is the characteristics of the patients that we see and who have been labeled as mast cell activation syndrome. So there is a predominance of females. So this is female predominant. And the age is a middle range age, so between 30 and 49 age. They have, some of them, associated medication allergies and or food environmental allergies. They have had many procedures, imaging, abdominal imaging, endoscopy, and they have been suffering with the symptoms for several years. Some patients up to 9 years they have had those symptoms for. What are the symptoms? Here you have them. So the symptoms of mast cell activation are mostly abdominal pain. 94% of the patients have that. Dermatographism, abdominal pain and bloating is very similar, so they feel there's something wrong. Dermatographism, what is that? We can write on their skin. So we do this and we can actually have a red line, and that red line means that they release histamine underneath the skin. So dermatographism, and the majority of the patients. Flushing, the tremendous majority of those patients. Headaches, so they have headaches. Poor concentration and memory, we were talking about that. And then other symptoms that are more gastrointestinal, so the diarrhea, the nasal-ocular symptoms, some of them have asthma, and some of them have severe episodes where they have what we call anaphylaxis, which is, as I was mentioning to you, when more than 2 organs are involved. If somebody has chest tightening, cannot breathe well, like wheezing at the same time, abdominal pain, bloating, diarrhea, nausea, those are 2 organ systems, and we are actually having a patient with anaphylaxis. These are, it's a busy slide, but I'll walk you through. This is what we measure in those patients. We measure total and mature tryptase. Total tryptase will give us the total amount of mast cells that they have, which is the mast cell burden, and mature tryptase will give how activated are those mast cells. And you see here that the majority of those patients have normal tryptases. Below 11.4 is normal tryptase, and you see that the majority have that. Some of them had elevations of tryptase, but again, the elevations of tryptase have to be coincidental with the episodes. So if a patient comes to us and says, I have those episodes that occur once a month, once every 2 months, where I have intense abdominal pain, and then I flush, and I'm itchy, and my brain fog is worse, and I feel tight in my chest, at that time, tryptase levels should be drawn. So we give the patients requisition, and they go to the hospitals, and the sticker has the name of the hospital, the place where the test can be done, the type of tube, and how the tube has to be preserved for the tryptase. Because when they come to the clinic, those patients typically are not actively having symptoms. And so two other mast cell mediators, so histamine, and we measure either histamine and it's in the urine, or methylhistamine. And so histamine would be the output of them, and methylhistamine, the metabolites of the histamine. And as you see here, the majority that is in bolded have elevated histamines. So in those patients with our preliminary series, those patients did present elevations of methylhistamine or histamine. And we also measure prostaglandin D2 or prostaglandin F2 alpha, which is a metabolite of prostaglandin in the urine. And those patients have elevated levels of prostaglandins. So essentially, in patients with mast cell activation syndrome, we can find a variation of mast cell activation. Either mast cells are active with elevated tryptase, which is the minority, or patients have elevated methylhistamine or histamine in the urine, or prostaglandins. So those are the ways in which we actually look at the patients and are able to assess this. We also looked at the gastrointestinal biopsies of the patients who have mast cell activation syndrome because of the prominence of those symptoms. Patients came to us and says, I have a biopsy and I was found to have 40 mast cells per high power field. What does it mean? Well, it doesn't mean nothing, because the mast cells need to aggregate, need to have spindle-shaped forms, need to have different markers like CD25 markers. So having an elevated number of mast cells doesn't make the diagnosis of mast cell activation syndrome. And indeed, when we looked at those patients, this is a tryptase stain and a c-KIT stain, the mast cells had a normal distribution, a normal phenotype, and were not increasing the intestine. So it was not the numbers that were important, but the state of activation of the mast cells. So the mast cells were active, they were releasing mediators, and their numbers and location were normal. You have here, as I was mentioning, that when you look at that in the duodenum, we can have in the normal range up to 50 mast cells per high power field, and that would not be abnormal. This is very important, because a lot of times they come to the center and says, I have mastocytosis, I have 47 mast cells per high power field in my intestine. Well, this is completely normal. That does not make the diagnosis. So this is a very useful thing. So how do we manage those patients with mast cell activation syndrome? So this is here a little bit the list of, it's not like a laundry list, but this is like the tools that we have available for patients with mast cell activation. And I was mentioning that in those patients, the major symptoms are symptoms that can be addressed with antihistamine H1 or H2 blockade. We do the long and short acting antihistamines, and things like loratadine, cetirizine, pexofenadine are the common long acting antihistamines. In our patients with mastocytosis and with mast cell activation syndrome, those antihistamines have a very weak antihistamines, so we have to actually double the amount that's FDA recommended. So if a patient is on cetirizine, we do 10 milligrams twice a day. And this is like off-label, so you can quote me. I mean, I think maybe I'm going to be taped, so the FDA can fire me. But essentially, the amount of antihistamine that those patients need is higher than the FDA recommended for allergic symptoms. On the other hand, we have something that's very important, which is sodium cromolyn. Sodium cromolyn is a chromone. It's a natural chromone that we have been using for the last 20-something years when I was a fellow and started to use that. The amount that is recommended is 200 milligrams 4 times a day, but that's not the amount that patients can take initially. We never have been successful at giving 200 milligrams 4 times a day before meals from the bat. The sodium cromolyn has a lot of side effects in the intestine, so we start with 100 milligrams, and every week we increase by 100 milligrams. So after 8 weeks, the patients take 200 milligrams on an empty stomach before each meal and bedtime. And at that time, there's a profound inhibition of mast cell activation. Aspirin. What is aspirin? Aspirin is blocking prostaglandin generation. So patients in which we found, and you saw in the previous slides that those patients have very elevated prostaglandin levels. I was mentioning to somebody, we had a 18-year-old a woman girl who could not graduate from high school. Her levels of prostaglandin were off the chart, like 4,000 picograms, and we found she was on antihistamines. We had trigastrochrome. We gave her 2 aspirins, 325 milligrams, 2 aspirins twice a day, so 1,300 milligrams of aspirin. It was like day and night. After a month, she was able to graduate from high school, and she's in college right now. So blocking the brain fog induced by prostaglandins with aspirin. Not everybody is able to take aspirin, and if you Google aspirin for mastocytosis patients, you can find also that some patients have intolerance to aspirin, and some patients need to be desensitized to aspirin. So it's not easy to use aspirin, but in our hands, and we have been very careful, this can be extremely successful in a subset of patients. In a subset of patients, also leukotriene blockade, patients who have respiratory symptoms and a lot of skin symptoms and swelling, that is very, very helpful. Leukotrienes are implicated in swelling of tissues and in bronchospasm. All the patients who have had an episode of anaphylaxis, or what we consider to be anaphylaxis to organ heats, need to carry an epinephrine injectable, but most of it, they need to be educated about it. So anybody who has passed out needs to have an injectable epinephrine. Most of the time patients come to my office and they say, yes, I have that EpiPen, and they show it to me and I say, well, use it. And they take it and then they start reading. And I say, no, you're passing out. You can't read. So if you don't know how to use it before you pass out, you cannot carry that. A lot of the patients, we have had 2 patients who have actually lost fingers because they injected the wrong way. So they injected the epinephrine in their finger. So careful about epinephrine and epinephrine has to be really taken with caution. There is a really new gadget and new device that I will not present to you, but it's a device that talks to the patients, and it's really, really cool. It's called OVQ, and I don't have any stakes in the company, but we have used it for a lot of success because it's like a small cell phone. And you can put it in the pocket. Our adolescent population with mastocytosis, they really don't want to have an EpiPen. They just hate that and they lose it. And so this is a very cool device. And when you take it out and you unfold it, it's like, are you ready to inject? And so it talks to the patient, and really, really helpful. Corticosteroids we use not in many patients, but patients with mastocytosis do require burst of corticosteroids when they're having severe symptoms, and that's important. Anxiety is a huge component of our mastocytosis patients, and coping with anxiety is not easy. They have a chronic disease. It's very important to do that. We do part of that. We ask them also to see to get some help, and we use. Gone. And can you hear me? No? Yeah, sure. Yes. Not in the back. I'll try to yell a little bit more. So the anxiety is a huge component of any type of chronic disease, particularly those diseases in which, unfortunately, at times people can pass out and they don't know what triggers can induce that. So this is a very important. And COX-2 inhibitors, we have used that mostly for pain. It doesn't take the role of aspirin, but pain is one of the other things that we have used, like something like celecoxib. We have used it and it's been very helpful. So this is one of the first studies that was done. I was not even a fellow at that time. Dr. Austin was my mentor, and he published that in 1979. And this is a patient that they use sodium chromoglycate who had prominent skin symptoms, who had central nervous systems, that the brain fog, and then gastrointestinal symptoms. So here is the patient in which they started disodium chromoglycate and then placebo. And so you can see that when they prolong the sodium chromoglycate, sodium cromolyn, you see here that the symptoms of the skin, whether it's flushing, pruritus, it disappears completely. The CNS symptoms, the brain fog disappears completely, and the gastrointestinal symptoms almost completely. So this was the first demonstration that sodium cromolyn was extremely helpful as compared to placebo for those patients with prominent mast cell activation mediated related symptoms, which address, again, skin, central nervous system, and gastrointestinal symptoms. So we have been using very successfully sodium cromolyn. We started very slow. We increased to 800 milligrams a day. Some patients need more than that, but it addresses many of the symptoms that mast cell activation is about. And in non-clonal mast cell activation syndrome, the response to treatment, you see here that this was our publication with Dr. Hamilton, who is a gastroenterologist. In the 18 patients that we did, we had a complete response, in a third mild response, and a partial response. So there were no patient that was not at least partially responsive to mast cell blockade. So this was very impressive to us. The criteria that we have for the diagnosis of non-clonal mast cell activation syndrome is here, and I waited till the end just to let you know. Most of it, and most importantly, when the patients are referred to our center, what we ask them is that they have been ruled for primary and secondary causes of mast cell activation. So if patients have flushing and hypertension, we say, well, this patient needs to be ruled out for pheochromocytoma. If the patients, and so we want the patients to be ruled out for the possibility of mast cells activating through other causes. So the number 4 is the most important for us. But then what are the criteria? So the episodes are consistent with symptoms that are relating to mast cell activation affecting 2 or more organs. So patients have skin symptoms, and you have here a variety of them: gastrointestinal symptoms, cardiovascular symptoms, respiratory symptoms, nasoocular symptoms, and we don't have here, but we have these brain fog and neuropsychiatric symptoms. We have to find a decrease of the severity of those symptoms with what we call mast cell control or medication. So the patient expresses those symptoms, and then we use the tools that I showed you before, which is that we use antihistamines, H1 and H2. We use sodium cromolyn. We might use, at times, aspirin. We might use leukotriene blockade. We might use corticosteroids at times. Epinephrine is available at all times. So we use that, and even we use leukotriene blockade as mentioned here. So all of that has to induce a decrease in the frequency and the severity of the symptoms. Now, the third one is the hard one. The hard one is that we need evidence of an increase in the validated mediators of mast cell activation. So when the patient comes to us and we have a baseline and we do a tryptase, methylhistamine, and prostaglandins, and there's no elevation, does it say, well, you don't have mast cell activation? No, it doesn't say that. We give the patients a requisition, and they can do tryptases, they can do methylhistamines, they can do prostaglandins at the time of their flare-ups, at the time of the symptoms, at the time when they don't feel well. Because most of the time when they come to see us, they actually feel okay. So that is the evidence that in at least 1 or 2 occasions that we require for the patients to have mast cell activation syndrome. And in some patients, to be completely honest, we sometimes have to wait 6 to 12 months to have that diagnosis, because the patients are placed on medication, the patients do well, then they don't do that well, we add another medication, and then they do a little bit better, and then in the meantime we have to grab and to make sure that we have one of the mediators. So this might take time. And again, this can be in blood and this can be in urine. Here, what we have is what was published by the Spanish group of Dr. Escribano and Alvarez Tose, in which they define when a patient presents to the clinic, what are the symptoms that would make us think the patient has a clonal versus a non-clonal mast cell disorder. And what was very interesting is that urticaria, angioedema, and dyspnea are symptoms that lean towards a non-clonal mast cell activation disorder. So the mutation of the c-KIT that I was telling you induces symptoms that are pre-syncope, syncope, hypotension. But when patients present to us and they have mostly urticaria or angioedema or dyspnea, those patients are unlikely to have a clonal mast cell disorder. And that's very important. Because in those patients, if that's the presentation, we can say we're going to treat you, we're going to give you medication that blocks mast cell activation, but you don't need to have a bone marrow biopsy. We don't need to do that because of your presentation, and this is validated now in many studies. So depending on the presentation of the symptoms, we can actually decide where way to go. And he also did an algorithm in which he actually helped us define which patients should have a bone marrow biopsy. And so the patient is a female and the patient has symptoms of urticaria, angioedema. That is unlikely to be a clonal mast cell disorder. If the patient is a male and has presyncope or syncope, the patient is very likely to have a clonal mast cell disorder. And I presented to you too at the beginning a male who is stung by a bee and presents a very severe hypertension. This male is at high risk for a clonal mast cell disorder. Now, tryptase level also here, as we were saying before, less than 15, and 15 is above the normal range, or more than 25. We're changing that because in a lot of the patients who have mastocytosis, again, we're finding that at least 10 to 15% of our patients' tryptase might be normal. So being a female and having urticaria puts patients at less category for clonal mast cell disorder. And this is what happened when, this is by Dr. Escribano, and he presented that at the Academy meeting in San Diego. Now, patients with mast cell activation symptoms, how many of them were mastocytosis? Well, 57% were mastocytosis. Non-clonal mast cell activation syndrome was 30%. So again, in patients who present to us as a center or presents to us at the clinic, we have to be really cognizant the possibility of idiopathic anaphylaxis being systemic mastocytosis or mast cell activation syndrome being the diagnosis of those patients. So I just will finish here. We have a mastocytosis center. It's in Boston. We evaluate patients with all the symptoms of mast cell activation. We send them some things to fill it up, a paperwork, they send back to us, and we require that the patients have had some studies before we see them. As I mentioned before, we require typically a tryptase, methylhistamine, and prostaglandins. If they cannot do that, a tryptase will do. And then if they have done any other studies like the biopsies, whether for the skin, the bone marrow, the gastrointestinal tract, we review those biopsies with Dr. Jason Hornick, our chief pathologist, and we provide a diagnosis. And if the patient comes to Boston, then we are able to do all those tests while they are there. And if indicated, we do the mutation analysis for those patients who are at risk of having a clonal mast cell disorder, and we also do bone marrow biopsies. So I would like to finish here. In this last couple of years, a lot of patients that have come up to us, particularly females, have been diagnosed with POTS. And there is a publication that indicates that a subset of POTS patients have elevated histamine in their urine. And those patients do have an improvement of their symptoms, so using antihistamines in addition to other things, in addition to a little bit of a steroid or beta blockers. But antihistamines have provided relief of their symptoms. So now we are paying a lot of attention to patients with POTS. Most recently in the last year, I have been having patients who come to me, they say they may have Ehlers-Danlos. And I know that in this audience, I'm preaching to the choir, but for me, this is something that we have not seen before. We had not seen patients with systemic mastocytosis or mast cell activation syndromes come to us and say, my joints, I had this patient that I told people already that had been coming to me for idiopathic anaphylaxis for about a year. And it's a very tall guy and had idiopathic anaphylaxis, has been seen by a couple of allergies in the community, anaphylaxis on allergy shots, and then they gave omalizumab, which is an antibody against IgE. So they thought, okay, anaphylaxis is the case, and he anaphylaxis on that. So he came to us because we are kind of the top leaders on what should be done. And after treating him for a year, back and forth, I was not sure what was going on. This past Monday, he told me, Dr. Castells, you know what? I can do anything I want with my joints. And I said, what exactly do you mean? So he took his shoe and his sock out and he just turned around his feet, and it's like, oh my God, I didn't know that. So he has Ehlers-Danlos, I guess, and I think he came to the NIH to be genotyped, and we're in the process of understanding, what is the relationship between his episodes of anaphylaxis and his hypermobility or Ehlers-Danlos syndrome. So this is an area that we need to explore. This is an area that I would be more than happy to collaborate, do research, and understand better. I see that a lot of you maybe in this room have had episodes of mast cell activation and you did not recognize them or were not sure what was it all about, and your doctors neither. Same thing for me. I did not know that some of my patients with mast cell activation may have had Ehlers-Danlos or may have had hypermobility, and I am interested in that. So thank you for your attention.